Hello, everyone, and welcome. My name is Kerry Pizzuti. I'm an industry PhD candidate at the University of Sydney and also a senior research officer at the Royal Australasian College of Physicians. Today, I'm going to briefly present my policy implementation gap analysis conducted with the Australian specialist medical colleges to understand how to best implement Australian continuing professional development standards for data-strengthened CPD. So first of all, I usually provide some clarifications around the terminology, so we are all on the same page. So for this study, there are two core terms that we need to clarify. The first one is electronic health data. And in this study, electronic health data is any personal information in digital or electronic format concerning the health status, risk, or outcome of an individual, and all pertaining to the provision of healthcare interventions and services to the individual. For this reason, electronic health data can include electronic medical records, electronic health records, registries, administrative data, claim and billing data, and so forth. The second term I usually also describe or define is continuing professional development. And for this study, I use the definition provided by the Medical Board of Australia. So for the MBA, CPD is the means by which members of the profession maintain, improve, and broaden their knowledge, expertise, and competence, and develop their personal and professional qualities required throughout their professional lives. Coming to the study, in terms of rationale, speaking of CPD, this study was prompted by recent regulatory changes in CPD requirements for Australian medical practitioners. Starting from January this year, in fact, all Australian medical practitioners must meet specific mandatory CPD standards to renew their registration to practice medicine. Among others, the biggest change to the standards was the introduction of compulsory reviewing performance and measuring outcomes CPD activities for a set minimum hours per year. To understand the magnitude of this change, it is extremely important to understand what has been happening in this space in Australia in the last decades. So in brief, until 2010, CPD was regarded as a laudable but voluntary activity provided by a wide range of organizations. From 2010 to 2022, as you can see here, the MBA standards don't mention a minimum hour requirement for CPD, nor they identify specific CPD categories for medical practitioners. In those years, in fact, the minimum requirements for CPD were set by the specialist medical colleges. The current CPD registration standards, effective from 2023, are completely different, as you can see. They set a minimum hour requirement of 50 hours per year. They introduce 3 CPD categories, and they also introduce mandatory minimum hour requirements for each of them. So in the last years, the MBA developed not only the current CPD standards, but also a regulatory framework called PPF, Professional Performance Framework, and several supporting policy documents, which state that reviewing performance and measuring outcomes CPD activities require the analysis of patient health data to be completed, and ideally the use of large electronic data sets and big data analytics technologies for better insights. As per their institutional role, the specialist medical colleges have the responsibility to interpret and also implement the MBA policy frameworks and standards. And we know that the colleges have faced several challenges in doing so. And this is the reason why I decided to conduct this study. So the study aim is to identify existing barriers and enablers for policy implementation, with the ultimate objective of providing the colleges with a list of recommendations to address identified barriers and tackle contextual influencing factors. So in terms of methods, I have decided to conduct a policy implementation gap analysis. First of all, I analyzed the content of existing policies and all supported documents, and I also studied the organizational structure and history of the specialist medical colleges in Australia. In terms of semi-structured interviews, this study is purely qualitative, And I decided to interview the CPD research teams and also the CPD teams in charge of implementing and interpreting the policy. So 4 colleges agreed to participate for a total of 18 research participants, and semi-structured interviews were conducted online and analyzed using a hybrid inductive and deductive approach to thematic analysis. So when it comes to the preliminary consider results. So what the findings show is that the colleges have so far focused on trainees' education and curricular development, considering original research on CPD of secondary importance, with the consequence of not being able to provide evidence and properly respond to the claims and requests on both the MBA and the college CPD committees, which are constituted by medical practitioners. Secondly, organizational culture, governance, and practices have created operational barriers, both at organizational and departmental level, for a smooth change in CPD management and development. Finally, external environmental factors are deeply affecting colleges' efforts. And just to name a few, one is medical practitioners' attitudes towards CPD, and the second one is lack of collaboration and shared vision at systemic level. And that's all from me today. Thank you.
Thank you very much for giving me time to present today. So what I really want to do is to talk about a certificate in clinical teaching and supervision that we developed mainly with researchers at the University of Newcastle. But before I start, I would like to acknowledge the traditional custodians of the land on which we gather today and pay my respects to elders past, present and emerging. So I would like to also acknowledge the fabulous team that I've been working with, particularly Kathy and Miriam, who developed a lot of the teaching content, and particularly Jenny May, who's helped to create the sustainability for these modules. Valley to Coast Charitable Trust also gave us a large part of the funding that allowed us to develop the certificate in clinical teaching. So the aim of the certificate was to provide educational support on the clinical teaching and supervision of educators who work in a primary healthcare setting. And we wanted to do this because we felt that there were lots of opportunities. Many of the primary healthcare practitioners are involved in clinical teaching, and they may not feel supported by the CPD resources that are currently available. And we really wanted to improve the learning for both the educators and our students. So the learning objectives were to facilitate effective workplace learning, which was really tailored to what the clinical educators wanted to understand and learn more about. And we really wanted to adapt the model where university teaching or hospital-based teaching was then being able to effectively being implemented within a primary healthcare setting. And we hope that by doing this, we would create a community of practice and encourage more practitioners to supervise and teach our students, but with real confidence, and recognise that the clinical educators will supervise undergraduate students, but they'll also supervise postgraduate students, particularly the registrars in GP practice. So when we were creating we first wanted to understand what resources were available and how were they delivered, and whether they were delivered sort of face-to-face and whether they're accessible in a rural and remote environment. We also conducted a survey with primary healthcare practitioners as well as some individual interviews to really understand from a needs analysis perspective of what did they want to see as being as content involved in the certificate. Using this information, we then discussed it as a group, and then we started to develop modules, and we've had many piloting and iterations of these modules over the last few years. And the sorts of things that the primary healthcare practitioners were asking for in terms of the content within the modules was how to have difficult conversations with the learners, particularly learners that may find the clinical environment particularly challenging. They also wanted to have more support on how to teach clinical reasoning and how to teach clinical skills, and how to give effective feedback and to understand if any of this feedback has been taken on board by the learner. They also wanted content related to communication skills, planning teaching, and creating a positive environment, which was for both the educator and the learner. There were also some other practical issues that we needed to take into account when developing these modules. So many people were asking for a flexible approach to learning. So having opportunities to engage with some of the content deliverers, but also being able to do this asynchronously at a self-paced, we also recognise that we have a number of busy schedules, so some wanted to have face-to-face. They were also asking that, you know, potentially wasn't on a weekend, so they were giving up, you know, valuable time to undertake CPD. We also recognise that the educators came from varying backgrounds within the primary care setting and had different levels of expertise, but also the learners were coming from different levels of expertise. So some were supervising undergraduate students who were mainly engaged with an observational placement, and then we had GPs who had GP registrars who were in that specialisation phase of their learning. And so it was important that content was delivered across this spectrum. So in total, we've now developed 11 modules, and to complete the certificate, participants need to complete the core module, which is module 1, and 4 other modules. But we've developed them in a stackable way so that learners can dip in or dip out. They can do one module, they can do several modules, and they are tailored predominantly to a primary healthcare setting, but they're also education, particularly module 11, which is prescribing non-drug interventions. We do have allied health educators as well as GP educators that are delivering the content. So to give you more information about each module is divided into parts A and B, and A and B also have pre-reading. They're delivered predominantly in PowerPoint, but there are pause points, which is really based on self-reflection. So this is to facilitate discussion, whether that's at safe-paced or reflection, or whether it was more discussion in a face-to-face environment. In order to complete the module, there are 2 short assignments, and these are generally just based on a single page to really reflect on current practice and how you might engage the content into future practice. So we're hoping that the certificate will upscale clinical educators, provide a flexible approach to CPD to really encourage a community of practice to improve the in-practice teaching and learning of our students. There are a number of engagement issues and sustainability issues, but we're very grateful to the University of Newcastle for continuing the funding. And to date, we've had more than 250 educators who have completed one or more of our modules, and a number of people who have completed 5 or more. It is available on Canvas through the University of Newcastle, and if you want to find out more about the certificate, then I encourage you to email the email address on the screen. And thank you.
Hi everyone, my name is Fran, and today I'll be presenting on a mentoring program my colleague Ali Tonks and I founded to encourage continual professional development amongst medical radiation practitioners. To date in Australia, there's been limited research on or provision of mentoring services within the field of medical radiation sciences that includes diagnostic imaging, nuclear medicine, and radiation therapy. So to address this gap, we developed the National Mentoring Program aimed at connecting individuals, fostering collaborations, and strengthening the profession as a whole. Since its establishment in 2019, the program has supported the development of hundreds of participants, from first-year students to leaders in the profession. Today, I will touch on what mentoring is and its benefits, what approaches we took to design our evidence-based program, and present some research results and learned findings. Mentoring is nicely summarized as a personal relationship in a professional context. It's a reciprocal partnership where the mentor provides guidance, encouraging their mentee toward achieving goals, and the mentee is proactive in establishing clear goals, learning openly, and sharing new perspectives. Now, there are numerous personal and professional benefits of mentoring. Most of us could intuitively identify the personal benefits, but perhaps less obvious are the flow-on advantages for an entire field, including increased retention and research output. In fact, one of our mentees indicated our program boosted their confidence at a time when they were unsure whether they wanted to continue with radiography. Now, there are numerous approaches to mentoring as listed here, which influence the success of a mentoring program. So I want to explain how we designed our program and why. Firstly, we used a structured program design. Individuals apply either as a mentor, mentee, or both, and applicants are carefully paired to best meet their needs. This structured approach helps create more security in the roles and responsibilities of each person within a mentoring pair. Now, our mentors may be assigned more than one mentee, but each partnership is carried out separately. Focusing commitment into one-on-one relationships is thought to achieve better individualized outcomes than in groups. We also consider the professional level of our participants. We strongly believe anyone can be a mentor or be mentored, and in fact, pairings of people closer in life stages or experience, like two students, can be more relatable, comfortable, and collaborative. Finally, we also match within disciplines where possible, because we believe a unique understanding of the professional environment helps with accurate advice. Now, to evaluate the success of this design, we use digital surveys to collect anonymized participant feedback at the mid and end points of the program. From a sample size of 80 active pairings, the response rate was 55%. And today I'll present some results from our 2021 endpoint survey. A large majority of participants reported our program was very or extremely helpful in their professional development. Moreover, while other mentoring programs do exist for allied health, all our respondents agree this program, targeted to medical radiation sciences, provides opportunities not previously available to them. From a list of predicted benefits as outlined here, over 70% of mentees indicated they experienced the full range of benefits to a great or very great extent. We also found the relative frequency of some benefits noticeably improved between rounds. Guided problem solving, for example, saw a rise following the introduction of a free mentoring workshop within the program. Looking now at mentors, in earlier rounds, they reported greater and more consistent levels of benefits than mentees. Although values remained high, we did see a slight drop in these levels at the end of 2021. While this might just be a statistical fluctuation, one theory for this change is that the mentors did not have enough time to realize benefits in full. Thus, in response to mentor requests, we've now moved from a biannual model to a single longer-term program duration to see if this change will positively impact the mentor development. So our program seems to have been well received, but we wanted to understand why. One possible reason is the care and time taken to manually match participants with detailed consideration of their interests, goals, expectations, and experiences. Indeed, many participants reported the quality of their match was good or excellent, and this influenced their mentoring experience. Another thing has been program accessibility. Communication preferences, be that Zoom, email, phone, or in-person, are considered when forming pairs, and participants are encouraged to meet at their own pace. Participants report this made the program achievable, flexible, and assisted with the frequency of meetings. Finally, supportive tools have also proven key. We provide various free and optional resources. Mentees identified email templates as the most helpful, and mentors valued our mentoring workshop most. From this, we better understand how our resources are being used and where to focus our efforts to develop future supportive resources and tools. So today, with over 500 hours of volunteer work, our program has become a platform for continued professional development for medical radiation practitioners. We have published our findings and have received the support from various bodies, including ASMET, Electa, and RADSOC. I hope this brief presentation has provided some insight into the power of a mentoring program for CPD in allied health. And if you're interested in learning more, please visit our website, Instagram, or send us an email. Thank you very much. Here are some acknowledgements and references.
Hello, everyone. My name is Eleonora Leopardi. My pronouns are she, they, and I am on Dark and Young Lang today to talk about our project, which is called, has a very long name, LGBTQI+, inclusive health professions education, producing meaningful change in the learning environment through faculty development, but we call it queer HP for short. I want to acknowledge that queer might be an upsetting term for many, particularly older LGBTQI+ people. However, the term has been reclaimed by many in the community, including myself, so I feel quite comfortable in using it. and I hope you can all appreciate how this term is now empowering to many people in the community. I would also like to acknowledge the traditional custodians of the lands that the JMP footprint extends on, and I've mentioned them in the Padlet. And I would like to acknowledge that this work is the product of the contribution of many, many people in the community that have experienced a great deal of harm, and they have generously contributed their time and experience to help us create this program. The project team is composed by myself, Dr. Katie Bird, who was queer rep and final year student last year. Sorry, just a second. Excuse me, I'm presenting. Okay. I hope this is not too loud. Professor Katie Wynn, who is the Year 5 chair of the Joint Medical Program, and Melody Van Wyck, the queer representative of the University of New England Medical Student Association for 2022. Through a series of conversations, we realized that we all felt that the curriculum was somewhat lacking in addressing LGBTQI+ health issues. And we wanted to see whether this has an impact in LGBTQI health outcomes. And in truth, these are Australian statistics. There are quite significant disparities for health outcomes for LGBTQI+ people. 3 of our 4 core team members are LGBTQI+ people, and we felt really strongly about addressing this. We also found, I'm so sorry, I'll have to. I'm so sorry about this. We were wondering then if our curricula help healthcare professionals support the increased health needs of LGBTQI+ people. And unfortunately, this is not the case. Well, we don't even know how many queer people are out there, as this information was not collected in the census, and there are no nationwide surveys investigating this. We found significant information from statewide surveys that indicates really huge challenges for LGBTQI+ people in accessing healthcare. And so we turned to the literature to see what we can do about this. Is it the case for added content in the curriculum? And unfortunately, we saw that this has been tried over and over and over, and still health disparities remain. So we were considering that the main issue is that there is a significant dissonance between the formal curriculum that we teach our students and the hidden and informal curriculum that is then transmitted through the institutional values, the culture, and the example and role modeling of other healthcare professionals in the environment. And we wanted to take on the very small challenge of reshaping the learning through changing the culture. We had a very ambitious list of things to do, quite aspirational. And so we focused on really one of these points, which was building educators' skills in facilitating discussions on LGBTQI+ patients. We considered that most of our students arrive in medical school with already quite a good understanding of gender and sexuality issues by virtue of being young adults in a modern and quite reasonably accepting society. However, the environment is often poisoned by the examples of senior clinicians who don't consider this and typically aren't informed about the health issues and the consequences that stigma and discrimination have on LGBTQI+ people. I'll need to speed through this. So we developed a faculty development intervention, and this was our aim. And I call this my little pyramid scheme, as we designed 2 trainings, a training inclusivity trainers, and then for them to deliver an inclusivity training to JMP staff members, producing hopefully queer-friendly future doctors. We designed our training, selected our participants, delivered the number of sessions, and we are creating an online faculty development environment for continued learning. There is an iterative sort of series of questions that we continue asking ourselves, and we are working on evaluating the impact beyond the specific knowledge acquisition in the training. I want to acknowledge that this is only made possible thanks to significant top-down support from our senior leadership in the Joint Medical Program, and that this is quite rare, unfortunately, in many institutions. So by funding this project and supporting our work, truly, I think the JMP is taking a great stance in pushing for better health outcomes for LGBTQI+ people. Thank you so much. This is my email if you would like to get in touch.